I'm going to start in a fairly light-hearted fashion. I had a builder come round to build a conservatory on the back of my house, and he was telling me that for 5 years he couldn't work. He'd had chronic fatigue syndrome. He was an ardent runner through woodland, and it turned out that after 5 years he was diagnosed with Lyme disease. So diagnosis is very important. Poor diagnosis can be catastrophic, as you can see from thinking about visceral leishmaniasis or malaria. You've probably heard about the famous relation of a politician who went on honeymoon to Africa, came back and he thought he might have malaria. So the GP came to see him, and on his bedside table there were antimalarials. So he said, no, you can't have malaria, obviously. You must have just flu, just see how you get on. Another GP came to see him and said the same thing. So then he went to hospital and he got on by dying and was diagnosed post-mortem as having malaria. So here's a clinical history. This is a lady who went to the Algarve for her holiday, and she came back and had the series of symptoms shown here. And she was diagnosed as having lymphoma. And the pathologist, the night before she was to have her spleen removed, looked down at the liver impression smear again and saw 1A mastigote. So she didn't have her spleen removed. She was treated for visceral leishmaniasis and survived. Unfortunately, that's not always the case, and there are cases in Europe when exactly the same symptoms have not been diagnosed, and the disease, leishmaniasis, has been diagnosed post-mortem. So you can see how much more dramatic the problem is in developing countries when they don't have access to reasonably sophisticated diagnostics. This is leishmaniasis. Here's a simple lesion, cutaneous leishmaniasis, and we don't know if this young man is going to progress to mucocutaneous leishmaniasis. There's no reliable test to tell us that. This is visceral leishmaniasis, which is what I'm going to talk about. And this young girl, if she's not treated, will certainly die of visceral leishmaniasis, symptomatic visceral leishmaniasis. We don't know which of these patients may go on to develop post-Kala-Azar dermal leishmaniasis. So there are several problems to be solved still in the diagnosis of leishmaniasis. These are the tests currently available, and Emily has discussed them or described them. Spleen puncture, if you waggle the syringe needle even a little, the capsule of the spleen will rupture and your patient will die of hemorrhage. It's quite difficult to find the organisms, not hugely sensitive, but the procedures, more importantly, are difficult to implement. There's a serological test, but it requires a bit of technical expertise. It's hard to get the hold of the antigen, and the reading of the tests is quite subjective. There's a skin test, but it's only positive after cure, generally speaking. There's the K-Tex, which Emily has mentioned, but has very low sensitivity. However, this test is quite good, and it's the mainstay of diagnosis in many regions. It's the RK39 serological test. You'll see it's very good in India, but it's not so good in East Africa. And that stimulated our interest through Tapan Bhattacharya, who's here, who was my PhD student at the time, now postdoc. So we posed these several questions about diagnosis of visceral leishmaniasis. Firstly, why does the RK39 test not work so well in East Africa? Is it due to differential immune response in the patients? Or is it something to do with the disease agent, the diversity of the disease agent in East Africa compared to India? And then we recognized, as I've just indicated, that there were several real problems in differential diagnosis of visceral leishmaniasis. Lots of people may be serologically positive, asymptomatic carriers, even though they never go on to develop disease. So how do you distinguish those people from the people in the pre-patent period who are going to get sick? When you treat patients, how do you know if they're cured? How do you know it's worked? That too is difficult. So there's a series of cases in which we need to have biomarkers to find out what is going to be the fate of the patient. So to look at the first of those questions, is the immune response different in East Africa compared to South Asia? We had collaborators in Sudan, Professor Saeed El-Safi, and in India, Shyam Sundar, and also to a lesser extent in Nepal. And we looked at the antibody responses in these clinical samples. And to do this, we had this design. Some of these slides may be slightly complicated, but I'm going to indicate the important points. So this is the design of the ELISA plate, where we had both Indian and Sudanese antigens on the same plate, and Indian and Sudanese sera, titering from left to right across the plate. If you look at the colours on this plate, you'll see that on the left side of the plate, the colour is much more intense than on the right. And that is also shown in this rather dramatic graph, where you see here are the immune responses in the Indian patients as compared to the immune responses in the Sudanese patients. So the antibody production is much greater in India than in Sudan. And that's one potential explanation of the differential performance of the RK39 assay. However, there's another, and that is the diversity of the disease agent. This slide here, just in the same context as the last slide, shows that the differential antibody titers don't relate to age or sex. We know that male and female immune responses may differ quite dramatically with a range of infectious diseases, including leishmaniasis and including trypanosomiasis, Trypanosoma cruzi, for example. It relates to the stage of development, whether it's pre-puberty, past puberty, and relates also to hormones, but we don't have time to go into that. But the response difference that I've shown you was not related to age or sex. You can see that in all cases, the green and the yellow lines are above the others, regardless of the age of the patients, and also regardless of whether they're male or female. To look at the diversity of the RK39 antigen in different disease agents in Sudan and India, we amplified up the region of the genome which encoded the antigen used in the diagnostic test. It's a repeat sequence, and 6.5 of the repeats are included in the antigen. So the way this was amplified was to use a flanking primer and a primer that occurred within the repeats, such that you get a ladder of products, and you cut out the amplified, PCR amplified bands, and then you sequence, and you derive the sequences of the individual repeats. And the results were quite astonishing. So there is immense diversity in this antigen, and this, as far as I'm aware, had hardly been looked at before. To look at this complicated image here, if you take the first two repeats, you see that where there's a square, that means that that amino acid is particular, specific to the East African organisms. This is looking at several different organisms against the antigen used in the assay, in the commercial assay. If you look at the circles, these are amino acids that are particular to South Asian strains of Leishmania. More importantly, notice that the charges have changed. Therefore, it's inevitable that some of the epitopes are different in these repeats. So we have two potential explanations. And this shows you that it's very important to look at the range of diversity of the organisms you're interested in, and also to use that as an aid to design of diagnostic assays. We still don't know exactly where the epitopes lie within this repeat sequence, although we've tried to do that. There's a new diagnostic test currently under trial, and this is the RK28. And this is based on two of the repeats from the kinesin antigen, plus HAS-B and HAS-B1 and HAS-B2 sequences, and these are antigens that were originally thought to be candidate vaccines. And we've also looked at the diversity within these, and we find that there's structural diversity in HAS-B1 and HAS-B2, but relatively minor amino acid diversity. It's yet to be seen quite how effective this is and whether this diversity affects the performance. The differences in the antibody responses in Sudan and India led us to wonder whether there are other ways of looking at differential antibody response. So this wasn't an entirely original concept, but we thought we'd look at the IgG subclass responses in patients with different clinical status. So we looked at patients before treatment with active VL, patients after treatment who were considered to be cured, and patients after treatment who were considered to be relapsed. And the results were quite extraordinary. If you look again at this image, which is quite complicated, just look at these two columns here. This is active VL, and these are the IgG1 specific antibody titers, and these are the cured. The antibody titer, IgG1 specific, using IgG1 specific conjugate, drops dramatically. Not immediately, because the IgG1 half-life is about 23 days, but it does drop, and this is looking at patients after 6 months, which is a normal time to look for relapse. And you can see the significance values here. So these are relapsed patients, active patients, and cured patients with the drop of titer in the middle. And the same was true with the Sudanese patients. And this just tells you that the other subclasses were not so informative. This is another representation of the same result with paired sera. So if you look at the central panel, you'll see that the mean value, absorbance value, for paired sera with the IgG1 assay dropped dramatically at 6 months in cured patients. The 6-month assay of relapse is quite usual, but unfortunately, relapses can occur very long after the 6-month period, and that's indicated by the two references given here. So in future studies, it's important to have a means of detecting relapse, communicating with the patients and detecting relapse beyond the 6-month period. If that is not detected, then the patients go back to their rural homes and are very likely to just die of visceral leishmaniasis. The interesting results with the IgG1 specific assay led us, in collaboration with Corus and the two representatives of Corus here, to develop a lateral flow assay to try and have something for point of care field use. So this is an assay in which we're using an IgG1 specific conjugate, and on the left here you'll see the presence of this second band indicates a large amount of IgG1 antibody in these patients who'd relapsed. And these are patients who were deemed to be cured. So you can see that you can get a very clear result. Not every patient will give you precisely this level of clarity, and that's summarized in the next couple of tables. There's also a poster out if you want to look at some of the technical details outside. So this summarizes the sensitivity and specificity. So a sensitivity level of about 95% to detect either active cases or cured cases. As I've said before, This is at looking at the 6-month point approximately, but you won't get a dramatic drop in the IgG1 response as early as 30 days after treatment. And the next slide indicates the specificity level that we have at the moment. These are with relatively low numbers so far of samples from India. So this is very promising because it's low cost, it's point of care, it's a few moments, and theoretically it's very promising to tell you that your patient who was treated before is or is not going to relapse. And in one of the patients who was classified as cured, a few days after having a positive IgG1 test, they relapsed. There's much more work to be done, of course, to validate this assay, but it does look pretty good. Also, it has some other interesting applications. We don't know what happens to the IgG1 profiles in PKDL, for example. Do they drop and then come up again, as appears to be the case here, or are they sustained in patients who've gone to PKDL? We don't know whether it's useful yet for looking at asymptomatics and whether they progress to symptomatic disease. But we've done a small amount of samples, and it appears that that might be the case. There's certainly quite a big difference. So the hypothesis is that if you've got a high IgG1 response and are asymptomatic, then you're an individual who's likely to progress to visceral leishmaniasis. Emily talked about whether patients could transmit to sandflies or not, and that's been an ongoing discussion for the last 40 or 50 years probably. The first work that I'm aware of was done in Brazil in about the 1950s by Leonidas Dini, and he's fed sandflies on asymptomatic cases but couldn't get infection, and fed them on symptomatics but did so with ease. But that is something that needs to be looked at in the future. But again, one might speculate, and we have absolutely no evidence at all, that if you anticipate a patient may transmit to sandflies, the first candidates you'd look at would be those who had an elevated antibody response. But as I've said, we have absolutely no evidence for that. So that's a summary of what I've just presented. The difference between antibody responses in India and in Sudan. The diversity, and this is a neglected area. It emphasizes the importance of looking at the diversity of your disease agents in different regions and also having access to them, because it's not easy to get these organisms. There are very few biobanks around the world where you can do that sort of work. I've pointed to a simple assay with IgG1, which is ridiculously simple but may be dramatically useful. A very simple lateral flow test developed by Corus. And it indicates that there's a long future in looking for other biomarkers in this way. There are very sophisticated technologies to look for biomarkers, much more so than this one. And I've mentioned that it may be possible to look at progression. And really everything I've said so far led me to want to give you a few general comments about diagnostics. Some of them are rather obvious. And diagnostics isn't our primary interest. We work mainly on molecular epidemiology of disease organisms, and we've come to this rather late through one PhD program. So it's essential to decide what you want in a diagnostic test. So many pieces of work are done, and they get to the end and say, well, maybe this is useful for diagnostics. So it's what I call a land of empty promises. There are lots of tests out there which are either not very good, and some of them are sold to make money, or they're promoted, but then they run out of steam, and a lot of effort is wasted. Obviously, it's important to validate tests that do have promise, and that's one priority of FIND, for example. But I would say that there's a lot more scope for newish approaches to diagnostics discovery. I've indicated one, which is the use of comparative genomics in looking for targets. But there's a whole raft of new technologies that are now available, either to find the antigen you're interested in, to make a synthetic peptide, to concentrate the antigen, or to look for biomarkers using sophisticated technologies. There's a whole list of them. And there are also new methods of implementing the tests using microfluidics and so on. There are also new approaches to epidemiology and surveillance. For example, looking at immune response to saliva in sandflies to monitor whether people are being attacked by sandflies and how those immune responses change in a scenario of control. You can do the same with malaria. And we've developed with Chagas disease a test which is using lineage-specific antigens, which helps you identify what type of genetic lineage a patient is carrying, and that may imply whether or not they go on to develop the horrific symptoms of chronic Chagas disease. So there I've used some rather specific work to hopefully make some general points and to encourage everybody to carry on looking for funding for diagnostics discovery. Thank you.
Thank you very much.